Bonjour, good morning. Again, I want to thank SAGES, obviously, for inviting me to speak today, and thank you again, Dr. Deese and Dr. Slater, for organizing this session. This is a small enough group, so this is actually be a good thing for us to discuss. I recognize some of our pediatric surgery colleagues, but I was asked to talk to community surgeons, rural surgeons, military surgeons, so that's really geared more, this talk is really geared for them. And if you're a pediatric surgeon, feel free to share your wisdom at the end of our Q&A session. This is my disclosure side. This is my financial disclosures as well as the funded research, none of which pertain to this talk. I'm going to talk about some of the things we can recall from medical school. For some of us, that's a little bit longer. And then we'll also talk about a clinical approach of how to diagnose Meckel's diverticulum, because you'll see that's not as straightforward as you can recall from medical school. So Meckel's diverticulum is a true diverticulum, meaning the fact it has all three layers. And if you look at the depiction on the right here, that shows you that a Meckel's diverticulum is sort of a blind tubular structure, but it's not always that way because there's many variants. You can have an umbilical attachment to the Meckel's. That could be a source of volvulus or obstruction. It can also be a sinus tract, it could be a cyst. And so there's different variants of phalangomesenteric duct, and Meckel's is only just one spectrum of it. If you look at that list on the lower left, you can see that those are the rule of twos, and I remember learning that from medical school, but if you look at the literature in the last 20 years, some of those are not true. For example, the ratio of males to females, the two types of tissues, there's actually more than that. And then, of course, the 2% that are symptomatic, and I'm going to talk about that in some of the other slides. These are some of the associated disorders that can be seen with Meckel's diverticulum. You can see esophageal atresia up there and perforate anus. But then keep in mind, you don't have to really work this up because the majority of patients already had that diagnosis way before you saw them at Meckel's diverticulum. It doesn't mean that you have to work up a cardiovascular anomaly or a neurologic abnormality, because only less than 5% are going to have those associated disorders. So when you're looking at Meckel's diverticulum, it's not as straightforward because the majority of them are going to be asymptomatic. Maybe about 4 to 16% are going to be symptomatic, and that goes against that rule of twos. I was taught like 2% of the population, 2% are symptomatic. It's actually a little bit more than that based upon a couple of studies recently. And if you look at the symptomatic population, this is just a partial list of some of the symptoms that you're going to see. Because of that, it's really difficult to work it up. And really the workup shouldn't be from screen, left here to screen right. It should be from the clinical presentation, just like most things in surgery, towards screen left. Now, I know this table is a bit busy, but I want to focus on the symptoms here. The symptoms could be, a GI bleed, could be an obstruction, could be an inflammatory process. We don't typically see tumors in children. We might see those tumors in older patients. But I think I want to highlight a couple of things that was a difference from when I gave this talk probably about 12 years ago. One is that I used to say the most common complication we used to see in children used to be a GI bleed, but recently it actually is obstruction is the more common thing that we see. We do see bleeds more common in younger patients, but when you get to teenagers and adults, the GI complications much less. For adults, you'll typically see obstruction and inflammatory process. So that's a difference between pediatric and adults. These are some of the typical things I have seen for Meckel's diverticulum. Sometimes I'll see it incidentally because I'm doing another operation that's unrelated, especially like for appendicitis. Sometimes I'll have right lower quadrant pain that mimics appendicitis, or abdominal pain either from obstruction or perforation. So these are the typical things that we see, but the most common thing that we see is a GI bleed. This is a list of some of the things you can order. A lot of them have limitations. A lot of them have advantages. It just depends upon the clinical presentation. I'm going to go through each one of these through the scenarios I pick. So the most common thing you're going to see, especially in younger children, or more commonly seen, I should say, is you're going to see a GI bleed in a young child, especially if they're less than age 10. Now, it depends upon if you look at the literature. If you look at the literature, if you say less than age 18, probably about 25% of those are going to develop a GI bleed. And that could be a bright red blood per rectum, that could be black tarry stools or maroon colored stools. It just depends upon where is the complication and how it's presenting itself. So let's go through this vignette here. So let's say you have a 2-year-old child, painless rectal bleeding. That's what we're told in medical school. And typically, You can look at non-surgical things to look for, but majority of those are going to have associated pain or painful defecation. You're not usually, for the community surgeons in the room, you're not going to be the first one to see it. Usually it's your primary care provider, maybe an ER physician, maybe a GI doctor. Typically they'll work up for infectious etiologies. They'll work up maybe with endoscopy, but it just depends upon where they're going with this patient. For you, you're going to get called because they've done the full workup. They've done the endoscopy, they've done the colonoscopy, the EGD, and nothing has come up, and now they're thinking about Meckel's. I've also seen that sometimes you'll have it's not very common, but you might see someone with abdominal complaints with bloody stools. Again, that's not the typical course for Meckel's. And maybe they got an ultrasound, or maybe they got a CT scan that shows a blind ending tubular structure. That's very suggestive of Meckel's, but that's not the typical way we do it. For you, if you're thinking about Meckel's, and Meckel's is pretty high in the differential, I probably would get the Meckel scan first. I know some people will differ on that, but the Meckel scan has less radiation than the CT scan of the abdomen and pelvis. And the Meckel scan has its advantages and some of its limitations, and I'll discuss that here. A Meckel scan does not tell you if you're actively bleeding. That's not the test that you should get. If you have a patient with active bleeding, you should get a RBC tag scan or a sulfur colloid test. That's the one you want to get. If you're thinking about a Meckel's, they shouldn't be actively bleeding. They're intermittently bleeding or they have a chronic anemia. It's detecting if they have ectopic gastric mucosa. That's the limitation of the test. It's highly sensitive in kids, and the reason why it's highly sensitive in kids is because they have more likely to have ectopic mucosa. In adults, it's less sensitive because most of those patients already had their symptoms early in life. There are certain diseases that can mimic it, such as inflammatory bowel disease or intestinal duplication. Now, there are some places, my previous hospital, we used to give pentagastrin, H2 blockers, and NPO and glucagon. That helps out quite a bit, but those things help uptake that ion into the gastric cell or help decrease the excretion. But again, talk to your radiologist. The current place I work at, we don't do any of these things at all. So going back to our scenario, you have a patient that has bloody stools. You've done your Meckel scan. You've done your GI consult. Sometimes it's still negative. In the literature, they've talked about small bowel follow-throughs and capsule endoscopy. They're probably working up for other etiologies. None of those are specific for Meckel's diverticulum. And for some institutions, depending upon your radiologist, you can do CT or MRI enterography. And even the current imaging that you have is sometimes better than the small bowel follow-through. We have stopped doing small bowel follow-throughs because the detection in other modalities is much better. So I would say maybe your GI person can help you unless you do your endoscopy, or a technetium scan would be better and stuff. But these other tests are rarely done. Let's talk about someone with abdominal pain. That's, again, an older patient, maybe a teenager, maybe someone who's greater than age 5. Looking at the recent literature, there's 2 studies in 2014, 2018, and they found that for kids, the obstruction actually occurs about 45 to 60%, and that's a higher number than I learned when I was doing my residency. Typically, that can be that band I was talking about that attaches to the abdominal wall that can cause a volvulus. It could be an intussusception, like a pathologic lead point, or it could be a lead trace hernia. This is this picture in the upper right. Let's see if I can see this here. This is a lead trace hernia, a strangulated Meckel's that's within a right inguinal area. Again, very uncommon, but these are reasons why you can have an obstructive picture. As far as inflammation, you can have a diverticulitis, you can have a perforation. I couldn't find the picture. I had one of my GI folks was trying to do a pill endoscopy. It obstructed the Meckel's. Well, that's how I made the diagnosis in the operating room, so. So you have a 6-year-old, this is a different vignette, 6-year-old patient with right lower quadrant pain, nausea, vomiting. Meckel's is not in the top of your differential. It's usually appendicitis. That's going to be your top of your differential. You can do the KUB, but the KUB is very nonspecific, so it's not routinely done for this particular scenario. I think the abdominal ultrasound is definitely the first thing you should do, because it's not just picking up for other things that we're talking about, like Meckel's or appendicitis, but it's a whole list of things you can pick up with your ultrasound. When you look at abdominal ultrasound, I looked up the literature, Meckel's diverticulum versus appendicitis. I thought it would be a little bit more clear-cut after about 15, 20 years of doing this, but it's not. I was told that if you see a fecalith, most likely that's an appendix case, but that is not necessarily true because you can have an intralith with a Meckel's diverticulum. Size, I used to be told that if you have a tubular structure about the size of the small bowel, that could be a Meckel's diverticulum, but there is no size cutoff that tells you that's a Meckel's versus appendix case. And then lastly, if you look at, where it's attached to, that's probably the most sensitive thing that radiologists will tell you. If it's attached to the cecum, obviously it's the appendix. And if it's distal from the cecum, it's most likely a Meckel's diverticulum. How often does this happen? Probably about 1% of the time. So it's very rare in your practice that's going to be an issue. But there are times that you go in for appendicitis and end up being a Meckel's case. And we're going to talk about, what do you do if you have a symptomatic Meckel's and an appendix case and vice versa. CT scan, abdomen, pelvis. Us pediatric surgeons, we try to minimize radiation. Same thing for most of you general surgeons, you're aware about those radiation risk. It's okay if you're looking for other things like inflammatory bowel disease or another entity that might be related, but usually if you're thinking about a Meckel's and stuff, do your appropriate workup, do your ultrasound. If your ultrasound shows a tubular structure, it's not going to change your management. Right, if you think it's appendicitis or Meckel's, you're going to go to the OR. So I don't necessarily go through this whole Meckel scan or CT scan. However, if those are negative, you can get the CT scan and looking for other etiologies, but I'll show you the CT scan is not really perfect. I think a Meckel scan is not really appropriate for abdominal pain unless they have bloody stools, unless they have anemia. Those are great situations, but it should be a limited value for patients with abdominal pain. And then lastly, obviously we're in SAGES, a diagnostic laparoscopy is your tool, right? If you don't know, if they've done the full workup, they've done their EGD, they've done their colonoscopy, the kid's anemic and still bleeding and you still don't know, you do a diagnostic laparoscopy and most times you're going to end up finding a Meckel's, at least in my experience. So here's the recent literature about CT scan of the abdomen and pelvis. Now it is better than it was before, but CT scans and picking up a Meckel's diverticulum, it depends if they're symptomatic or not symptomatic and their age. So if you look at symptomatic patients, that's anywhere between 55 to 60%. It's not great, but it's better than it was probably about 15, 20 years ago. If you're asymptomatic, that number drops dramatically to 25 to 40%. So not a great test if it's asymptomatic. I think it increases as you get older because you need peritoneal fat to sometimes see that. And so in younger patients, the CT scan might not be ideal. And so think about the limitations when you're getting a CT scan. If you're saying, I'm going to get a CT scan to rule out for Meckel's, it's probably not a perfect statement. So you can't have a SAGES presentation without a laparoscopic video. So I just want to thank Dr. Mukherjee. I don't know if he's here or not. His video is much better. Thank you very much. Thanks for your video. This is a laparoscopic Meckel's diverticulectomy. And there's different ways you can do it. You can do it as seen here and do a laparoscopic bowel resection. Or if you're not comfortable in doing that, just make the incision probably about 2-3 centimeters along the belly button, eviscerate like the pictures here on the lower left, and then you can do your bowel resection. You can do a diverticulectomy, you can do a segmental resection. If the base is wide or if it's an active bleeding case, I recommend doing a bowel resection. Again, keep in mind that if you're going to do a diverticulectomy and there's some irregularity of that bowel, I recommend you to open that specimen because if there's some irregular tissue at your staple line, you might be leaving gastric tissue, and that will still be a problem for that patient. I want to bring this one up about incidental appendectomies. There's been a whole host of literature looking at whether you should do an incidental appendectomy. When I was a resident, and we did a intussusception case or maybe a Meckel's case, I would take out the appendix because I heard there was no risk. And that's not true anymore, because if you look at some of the literature, we actually looked at this question for intussusception, both pathologic and idiopathic. And you can see that incidental appendectomy is associated with increased costs, increased hospital stay, as well as a possible increase in postoperative bowel obstruction. This is the same that they're defining in trauma. This is the same thing they're defining in for malrotation. So what I learned, 15, 20 years ago during my residency and my fellowship has changed quite a bit. So if you have someone who has a symptomatic Meckel's and that is the cause of their disease, When you take out the appendix, you can take it out, but you have to be honest with those parents. You know, it doesn't come without its risk. It's not 0% risk. So in summary, symptomatic Meckel's diverticulectomy, all of those should be taken out. Those require surgery. The most common symptoms depend upon the age. It could be obstruction, bleeding, or inflammatory processes. The clinical presentation dictates what test you should get. And the Meckel scan is great, but it has its limitations, especially if it's, you know, the age of the patient and if it has gastric mucosa. And then I already talked about that last part there. Again, thank you for your time, and I'm open for any questions.